a lot of use of opioids, either natural or synthetic. Okay, so these are the beginning or introductory information for you. Now I have to recall some of the information from you. That is, defined pain is the either sensory or emotional experience associated with the actual or potential tissue damage. This is definition, but I want to know how you can classify pain pathway. Can you classify pain pathway?
The spinal thalamic tract.
It means you are meaning ascending tract.
Yes.
Okay, so spinothalamic tract or ascending tract. Spinothalamic tract normally convey what?
Pain and temperature.
Pain, temperature,
Pressure.
touch.
Touch and temperature. Okay, that really answering your somatosensory, mostly somatosensory, right? Your spinothalamic tract, they carry mostly somatosensory. How about, is it important? Is it only way, if I rotan you, or physical trauma is the pain? Emotional trauma is not pain? So, are you familiar with the spino-reticular tract? Have you ever heard of?
Yes.
What is the function of a spino-reticular tract? Anybody can Google for me?
Emotional pain.
Huh?
Emotional pain.
Yes. So this chapter, although most of the time we try to focus on minimizing sensory pain, but the outside world, the naughty people, drug dealer people, mafia people, they know some of this drug really going to suppress your emotional trauma as well. Okay, so you may can use in a good way, or you may can use it in a bad way. So far, all over the world, heroin, pethidrins, equally using among the non-justified users. I mean, addiction abusers, right? Am I correct?
Yes.
Have you ever heard of morphine addiction? Is it common in Malaysia?
Ketamine, doctor.
Sorry.
Yes, doctor.
Yes, yeah, all over the world. Let me go a little bit on this. You see Afghanistan. Why so famous? Why Russia want to conquer Afghanistan? Why USA still today their soldiers in Afghanistan? There is nothing, just hill and some tents, and they are deploying million trillion dollars of bombs and weapon only to kill those hilly poor people. Is it the reason? Is it? Afghanistan is one of the area very much suitable for cultivating poppy tree. So later on throughout the class, you'll be know we actually extract opium analgesics from opium plant. So not many part of the world they are very good in cultivating poppy trees. So that is one of the place. The reason $1 trillion business up there. So this chapter today is not only for therapeutic potential, but also having so many legal and abuse related problem. So today our focus will be as a analgesics. So drug morphine is the most strongest painkiller in this world. In this world, nothing can inhibit pain better than morphine. No, nobody. The best drug, the strongest drug in this world to combat with the pain is morphine. So in this chapter, we'll try to focus the analgesics because morphine can be used for anesthetic drug also. But we'll not go in details about that. There are so many operations, military operations, so many gynecological operations, orthopedics procedure you can do with the morphine, but with just little bit giving some touch there, not really in details, but in details we'll be going only for how morphine can use as a most appropriate analgesics agents. Now, what this picture is telling, what type of person he is.
Dependence.
Yes, so he is a drug abuser, morphine abuser. Most of the time, one good thing about morphine, if you give somebody morphine, they will have total loss of reality. They cannot remember what happened to them. So sometime, even police department, military department, if they pick some of the suspicious people and they want to extract some truth, so some partial dose of morphine actually it can be used. The reason why they become totally disoriented. So every country you have a drug and narcotic department. You don't have only a drug department, also there is a narcotic department. So there are some group of drugs. What they do, they bring your CNS condition in such a depressed way, and you'll be totally drowsy, disoriented, and from there it is so difficult for you to bring into reality, or until the drug is there, you'll never can be react properly. Your reflexes, your drowsiness, your all tone will be very much diminished. So these people are really, really kind of semi-conscious. They don't have any response with the outside world. So that is narcosis. Alcohol is a narcotic substance. Uh, uh, you know, um, Opium and some other synthetic variety of opium also narcotic substances. So every country they have a separate department for this. So normally in morphine is not only causing hypnosis. Do you know what is hypnosis?
It's like the person feels like in a trance.
There are two type of sleep. Some people sleep a very moderate light. If some even a cat coming to the room, they wake up. Some people, if you blow dynamite in their room, also they cannot wake up. From the Okay, so hypnosis is a much more deeper state of CNS depression. CNS depression, it has four fundamental steps, as it is dose dependent. The most lighter dose of CNS depression, or the early symptoms of CNS depression, is angiolysis, then sedation, then hypnosis, then coma and death. Eventually, with any sleeping pill or morphine, if you go dose dependently, it will be starting with the angiolysis, minimum dose. Then if you increase the dose, it will cause sedation. You can sleep. If you increase further dose, it will cause hypnosis. If you increase further dose, it will go for coma and death. So what does it mean? This drug has a very high curve of dose response curve. Saturability of this drug is very, very low. So this is actually we want it. You want to do a gynecological procedure. You want to do a dressing a bullet shot soldier. I want both of these. I want when I'm doing the dressing or I'm removing the bullet, there should be no pain. And following my operation, patient should be in a deep sleep. So when my procedure, everything done, they can be wake up. So it can be used in either direction. So narcosis is a condition of CNS depression where patient will be stupor. It means very deeply sedated, very strong sleep. Very difficult to arouse them from the sleep or from the state of CNS depression. So most of the time abusers, they are very, very drowsy, and many movies, many serials we saw, and HIV is one of the reason. That's why multiple user, if they use one needle, mostly they take actually morphine. So many transmitted diseases like hepatitis C, HIV actually transmitted through this kind of abusers. Okay, this topic is little bit very funny. All of us, we have some natural opioids inside our body. How to give example on that? Male or female? Who can bear more pain compared to male and female?
Who can stand more pain? Is it?
Yeah, who can sustain the pain? Who can absorb the pain better among the male and female?
Female.
Female can absorb better pain.
I think
Seriously?
male.
Male. So if we do the sex distribution of pain modulation or pain absorption, definitely men are much more stronger, stable compared to emotional trauma, compared to physical trauma. Men have better responses against the pain. The reason we men, we are secreting more endogenous opioids. Let's take another example. You swap your work with your mate. One day you ask your mate to do all work you do, study, attending the class, attending for exam, Facebooking, WhatsApping. But if you have a mate, what they do? Washing your cloth, sweeping your floor, mopping your houses, cleaning. If you stop your work for one day, you cannot wake up from the bed for 3 days. The reason, the worker from Bangladesh, the way they're working in the construction farm, the way they're working in the agricultural area in this country, I cannot stand that even for 1 hour. The reason, occupational history, physical exertion, somebody is athlete, somebody is bodybuilder. So their endogenous concentration of opioid will be high, especially endorphin. Endorphin, there is another name. Is there anybody who can tell me?
Endorphin high.
What is the common people, what they call it, endorphin?
Stress hormones.
Stress hormone or hormone of happiness. If you laugh, if you are in a healthy environment, you will be secreting more endorphin. So that will not only make you happy, but also it will enhance your pain tolerability. So inside our body, Almighty Allah has given us three opioid-like substances: endorphin, enkephalin, and dynorphin. So if you go through, if your childhood was in a boarding school, where you've been challenged in different area of life, definitely your concentration of endorphin, enkephalin, dynorphin is higher. So when you come to the cruel real world, probably you can stand better. So this is not fixed. Our lifestyle, it really can modulate the concentration of endogenous opioid. So our general people pain tolerability, somebody from loyal family, do you think their pain tolerability will be same? Or physical exertion capability will be same? Probably no, because general people, we are having higher concentration of endorphin. If you compare children, male and female, children, very sensitive, very fragile. So it means still their body is not secreting that much of endorphin compared to female, compared to male. So male, we are containing highest concentration of this, so that we can stand better with the pain. So endogenous opiate precursor molecule presence in the CNS, and it has been related with the pain modulation. Higher the concentration, lower the pain perception. This sentence actually describing that. So if you know, some people, they take everyday laughter therapy. There is a reason. The reason, they want to enhance their endorphin therapy. If you're in a healthy relationship, in a family, in a personal life, you are actually enhancing your endorphin concentration. So that not only giving you happiness, but also preparing you to be compared with the cruel outside world. You can stand better with the stresses. Okay, so this is our endogenous opioids we have inside our body. Now, these are all hormones. So any hormones ligand cannot work without a receptor. So you need a pain receptor. So it can be released during the stressful conditions such as the pain. So what happens if you have more? Then you'll feel less pain. Now, those are all hormones, local hormones. So what happened? they should have a receptor. So we have three opioid receptor or pain receptor, mu, delta, and kappa. Have you ever heard of this receptor before?
Yes.
You heard it, right? Okay. So this receptor, Almighty is very, very scientific. So he already know. Now, who can tell me the primary neuron in pain pathway? What is the first order neuron?
Alpha.
Again, alpha is the neuron, right? Is
A
an
delta. A delta.
What is the receptor? What is the receptor for, or what is the primary first order neuron for pain pathway?
Nociceptor.
Okay, nociceptor or free nerve ending, right?
Yes.
It is better to say free nerve ending because it is the terminal part of the body. So our skin mostly containing a lot of free nerve endings, and those are our first order neurons. So if you're exposed to heat, if you're exposed to temperature, if you get a prick by a pin, so everything pain starting from your first order neuron, that is your free nerve ending. Okay, what is the second order neuron?
Spinal cord.
Very good. Which horn?
Dorsal horn.
Why dorsal horn?
Because the dorsal horn is the one that contains the
Why not ventral? Why not ventral?
ventral motor.
Very good. So answer is dorsal horn concerned with the sensory. Sensory is actually for pain touch temperature. So very good. So throughout my discussion with him, we find out for ascending pain pathway, we need two very important elements. Those are first order neuron, which is free nerve ending, second order neuron or dorsal horn of the spinal cord. These are the two major things, right, determining your pain. After that, there is a one final station, final relay station for pain, that is thalamus. Correct or not? Betul?
Betul,
Yes.
betul.
Yeah, it helped to to give you information, site of the pain, intensity of the pain, and decide what type of efferent should come. Whether you keep your hand in the fire or not, if you're getting a mosquito bite, whether you should kill that mosquito or not. So third order neuron into the thalamus. So what do you think? All these receptors should be located mana? As they are pain receptor, so they always try to reduce your pain. So what they should block? Mu, delta, and kappa normally remain our first, second, and third order neuron of pain. So afferent nerve or free nerve ending, first order neuron, right?
Yes.
Then dorsal horn of the spinal cord, second order neuron, right? Okay, so medial and lateral thalamus, so third order neuron. So all mu, delta, and kappa receptors are already located here naturally. Because why? If you get a strike on a door, or you just got a small injury, you need not to take any painkillers. You feel pain for a while, no problem, but maybe after 5 minutes you don't feel the pain anymore. How that pain been vanished? Have you ever thought of? Betul tak?
IPSP.
Not really. IPSP, you have to have postsynaptic potassium channel should be open. But here, because pain and inhibition is two different story. Here, how if efficiently you can block transmission of your initial impulse toward the pain. That is your standing with the pain. That is your pain modulating pathway. So here, the distribution of mu, delta, and kappa receptors are showing mostly mu because mu is the most significant pain modulating receptor. So mu actually will get all afferent nerve, dorsal horn, and thalamus. So first order, second order, third order neuron all can be blocked by mu delta, by endorphin in mu delta and kappa receptors. So here, So you can see the location of mu1 receptor, kappa receptor, and delta receptor. So from their location, analgesia is almost everywhere common. One good thing about mu receptor, why it is the most important pain modulating receptor, because it remain even in the free nerve ending area, primary neurons area, but all others are actually spinal. So either in the dorsal horn or into the lateral funiculus. From there they do the crossing over and they ascend toward the hypothalamus. So location is very, very important. Supraspinal, what does it mean, supraspinal? Hmm?
Supraspinal is above your spinal cord.
Yeah. So it can be in both direction. It can go until the thalamus or even can be in the free nerve ending. So it not only focusing on the spinal or the dorsal horn or into the lateral funiculus. So at the beginning, I think I mentioned somewhere the main pain modulating receptor actually mu receptor. Can you remember that?
Yes.
Yeah. So who are the agonists? Naturally you should imagine you really every day you facing some pain, you're getting strike or different objects, some minor injuries are there, but you are not taking any medication. So agonists are at that time endorphin, enkephalin, and dynorphin. However, there are some specific agonists are there. So this chapter today we're going to discuss more about all these agonists. So we already discussed what are the location. So mostly mu receptor, spinal and supraspinal analgesia, sedation. That is the adverse effect because it is very diversely present in the brainstem. Also, it present. So inhibition of the respiration, slowing your GIT or constipation. Okay. So endorphin, it has much more affinity for the mu receptor. So opioid, they really try to mimic the action of endorphin. So if they try to mimic the action of endorphin, so what they do, they mostly occupy mu receptor. So next time, if anybody asking you or you're thinking of pain receptor, actually it should be majorly mu receptor. And major endogenous your pain inhibiting neurotransmitter actually is your endorphins. Delta receptor enkephalin is much more selective for delta, and it is no more not as strong as it is with the mu receptor. So kappa almost also same. So dynorphin should be the agonistic here. So we at the beginning we decided there should be there are three endogenous opioid neurotransmitter for us, hormone for us: endorphin, enkephalin, and dynorphin. We also said there are three specific receptors that are responsible for transmitting our pain from at the different pain sending pathway. So each of them are mu, delta, and kappa. Some of them they're present in the spinal, some of them they are present in the supraspinal area. So I think before going for any drug, starting this chapter, you really have to master of these receptors, endogenous opioids, their location, and what type of functions they're doing. You have to know it. This gentleman, his name is Frederick Wilcher Schartner, a German scientist. He actually won Nobel Prize once he discovered the morphine structure. So morphine actually it's a Latin word, and it is called dream of it's a god of dream, Greek god of dream. So what does that mean? If somebody take this drug, they really lost their touch with the reality. So if they lost money, they cannot remember they have lost money. If they have family crisis, they cannot remember it. They will be really, really floating into the sky. It is as good euphoric drug, the best euphoric drug in this world, and that's why abusers are love to take this drug. Okay. So this is 200 years on 200 plus years old drug in the industry. So let's go with the morphine. So anybody you are planning of building your career in surgery, either in orthopedic or any discipline of surgery, it is a everyday bread and butter for you. There is no pre-operative, intraoperative, and post-operative hospital in this world where they don't use morphine or pethidine. So I said three phases: pre-operative, intraoperative, and post-operative. Everywhere, different agents, but opioid agents are using in surgical department. So this is the most active NH3 receptor that is responsible for the N-methylpyridine NCH3. Why it is important? Because from morphine is short acting, very very strong, but people can die very easily. So that's why they're very careful and they're using this bond, and they're synthesizing some other agents. This is the reason I think I told you why people are so curious about Afghanistan. Afghanistan is the best area in this world to cultivate poppy plant, and it, I think it's very natural. They just collect the extract, they just dilute it, and they market it. So operational cost is very minimum. So they just plant the seeds. When fruits is ripened, they collect that extract, they just dilute it. There is not much purification because morphine is the natural source one. So production cost is very less, but they can sell it trillions of dollars. So there are a few steps how they do it. Firstly, they give a vertical incision in the seed. Then they'll be waiting until evening. You know, they the liquid, it will be deposited into their skin. Evening they'll be coming and collecting it. Just they're doing dilatation. Following that, they do it marketing. So very easy source of money, and very it's one of the expensive drug, morphine. So morphine classification is very important. Natural one, phenylketonuria group. Don't you need not to remember the nucleus, but the agent. So naturally morphine, codeine, and thebane. These are the three naturally occurring drugs. The highest percentage actually is the morphine. Benzyl isoquinoline group, papaverine, and also narcotine. So these are natural morphines are there, or natural opioids are there. So at the top is actually morphine. Semisynthetics are semisynthetic. Why semisynthetic? As I said, they just take NCH3 compound and they put in other structure, so it become diacetyl morphine. So that is actually heroin. Many part of the world, Russia, Colombia, some part of Southeast Asia, is very common and popular drug for addiction. I never saw in Malaysia anybody taking heroin. Is there any heroin abusers are here? Hmm? Because in I never saw in any movie. So what happened? It is a powder-like substances. They have to heat it and it try to evaporate, and they take the sniff. So inhalation route they're taking, and they become euphoric for a long time. So this is one of the very popular drug heroin to do abuse of, misuse of this drug. Dihydromorphine, oxymorphine, and dihydrocodeine. These are the semi-synthetic drug. So these are actually substitute to morphine. Many gynecological word, most of you know, normal delivery is very painful procedure, and for a first-time mother, the pain can exist for 6 to 7 hours. So sometimes it is very difficult for the mothers to tolerate the pain. And with the development of the anesthesia department, probably you have heard about the epidural anesthesia. So some people using invariably, heroin or pethidine, actually, not really heroin, pethidines, they are using for epidural anesthesia to give birth painless normal delivery. But that anesthesiologist have to be very skillful to exactly in epidural space they can inject the anesthetic drug. So this is synthetic, or this is synthetic, and nowadays all pre-anesthetic medication they do it. Fentanyl, alfentanil, sufentanil. These are the drug of choice nowadays for anesthesia. Why? Because gaseous anesthetic drug, most of them are hepatotoxic. So what they do, they try to reduce the either halothane or nitric oxide. So how they can reduce the concentration of halothane and nitric oxide? Because they simultaneously, during the operation period, any of them is common, must be. If pethidine, as I said, meperidine or pethidine, mostly using for epidural anesthesia, but a general surgery, cholecystectomy, laparotomy, anything, they use as a combination with inhalational drug is the fentanyl or sufentanil. Although you have a option for ketamine, but ketamine is very, very expensive. Almost effect is same, but if your patient cannot afford to buy a pure injectable general anesthetic drug, there is an alternative for you, for that is fentanyl. So many operations we saw along with the gaseous drug, they using fentanyl, synthetic opiates. Diphenoxylate is a tablet. If severe diarrhea, you have to use it, because although cause may be infective, cause may be osmotic, but doesn't matter. If you give morphine kind of drug, so they will reduce the peristaltic movement. So it's a very common popular drug for reducing peristalsis, loperamide. Okay. Methadone is given to the addict. There is a, it's a actually pseudo agonist. Although it is synthetic, it's a pseudo agonist. It has only 10% potency like morphine. So what happens slowly once you are withdrawing, most of the rehabilitation center who dealing with the morphine addicted people, they actually giving methadone. It's a very weak agonist, 10% of original morphine potency they have. So there will be less chance of withdrawal effect of the morphine poisoners. Okay. Dextromethorphan, I think all of you have to remember this drug. When you're doing your clinical practice, you'll be seeing so many patients coming with a dry cough. If any of you travel to, some part of like Delhi, Dhaka, where the environment is not good, pollution is there, or if you go sometime in Malaysia, you saw Indonesians, they burn the tree or their forests and all the, haze and everything coming to Malaysia. 2-3 times I already experienced it. During all those outbreak, those small particles, nanoparticles, what they do, they cause irritation to your lung. So this is the best drug in the world for cough suppression, dry cough. The cough because of irritation. So previous in one class we said ACEI inhibitors can cause dry cough. So those patients, if they cannot buy receptor blocker, we actually give them dextromethorphan syrup, and nothing will work better than this. There are two syrups available for dry cough. One is codeine, one is dextromethorphan. If you take codeine, it will cause drowsiness, So if you got an adult smoker, and because of smoking, they're having very intractable or unbearable dry cough, especially about the wife, they also cannot sleep. So how can you give relief to that smoker with this dry cough problem? Most of the smoker, they cough. So what do? You give codeine syrup to that man, so that it's not only going to inhibit his cough center, but also it will produce sleep for him. So both of them can sleep nicely. If you want sedation and cough suppression, go for codeine. If you want only cough suppression, somebody, a pilot, or you're planning to travel to from here to Kelantan, you want to drive, but you're having coughing problem. At that time, if you take codeine, you have to sleep whole day in RNR. But if you take dextromethorphan, without jeopardizing your driving skill, you're really going to inhibit your cough. So these are very, very everyday handy drugs. In those concerned departments, very commonly they're using these drugs, very frequently. So these are the classifications of the drug. Why we should know about morphine antagonist? Any idea?
Case of morphine abuse.
Very good. It is a very, very popular drug for abuse and even suicide. From my medical school, when we are in year three, one of our friend, he closed the hostel door and he suicided with morphine. One of my cousin, because of his emotional matter, somehow they know all this. And in the the underdeveloped country, it is so easy to get the drug. They buy the drug and they push in their vein and he pass away. So morphine-induced suicidal tendency, attempt to suicide, very, very common all over the world. Even sometimes junior housemen, sometimes you don't really follow some of the coexisting problem with the patient. So in hospital setup, whoever you give morphine, your word, your that floor should have naloxone because different people they show different kind of sensitivity and response to morphine. Some are well tolerable, some really can show adverse effect very quickly. So at that time naloxone or nalorphine, naltrexone, any of them full antagonist can save the patient. Okay, so as morphine is the most strong painkiller, but also it has some adverse effects, so we have to really know about the adverse antagonist. So there's a mixed acting drug, nalbuphine or butorphanol, also used for abusers. They are taking in the rehabilitation center. They are giving this drug, but they will not get the full effect of morphine, and slowly, slowly, you can withdraw them from the addictive drug. So most of the rehab center they are actually using this drug. Distribution has absorption. I think as it is, nobody give actually except synthetic drug. You cannot give it orally. So completely rapidly absorbed after IM, any internal route, but you cannot give it orally, especially morphine. But codeine other you can give because morphine orally it has some enzymatic destruction. Secondly, very high phosphorus metabolism. But codeine we can give tablet. So why it needed so high dose? Sometimes patient cannot tolerate it. So better always use morphine intramuscularly. Intravenously also sometimes very, very dangerous. So most of the time, whenever we inject, we actually prefer morphine to be in intramuscular route. So a mother is, screaming on labor pain, and you are very kind-hearted doctors. Will you going to inject morphine to this mother? IM or intravenously? Are you? What is your answer? Hello.
Uh, yes.
Yes. Then you have to wash your hand from your license. You cannot give intravenously or intramuscularly to a mother in the labor pain. You cannot do that. So very highly lipid soluble drug. It has wide volume of distribution until it can go to it can cause the placenta and it will cause fetal respiratory depression. So you make mother may can deliver a stillborn baby, or the patient will be very, very slow responding after the birth. So poor cry, Apgar score will be very, very low, baby will be cyanosed. So you have to really send this baby to neonatal ICU, and it will cost a lot of money. Only way you can give that also not morphine, pethedrine, you should give to epidural anesthesia, but not as a pain reducing substance. Okay. So what happened? It will transfer to, it will cross the blood-brain barrier, it will cross placental barrier, and it will accumulate into the fetus, and there will be fetal respiratory depression. So baby will born with a poor Apgar score, cyanosed baby. Okay. Metabolism. Always, anybody saw morphine ampoule or vial? Did you saw? Anybody saw? Any idea about dose of morphine? Morphine usually given in a smaller dose. Never it is more than 5 ml or 3 not 10 ml, not more than that in a liquid form. The reason, small amount of morphine has the capability to be very active within the body. So active metabolites of morphine, morphine 6 glucuronide. So if you give a small amount also within body as a metabolic byproduct, it will form a very potent intermediate compound. So that really can serve your purpose for long. So that's why, like if I'm not mistaken, pethidine we give 100 milligram, whereas morphine we can give only 5 to 10 ml. The reason, morphine producing active metabolites. Elimination is by the urine. Duration of action vary 3 to 5 hours. I saw even 3 ml. Never ever any hospital will keep 15 to 20 ml. Yes, they may can. I saw once only. I had one patient come for cesarean section, and we want to give epidural. She took 2 to 3 vial. The reason, when you took the history, she's a chronic alcoholic person. So if somebody is chronic alcoholic person, trust me, it is so difficult for them to get inhibited by the anesthetic drug. So difficult. Only those cases I think I saw 2 to 3 vials of using, but normally it started with 3 milligram, maximum 10 milligram use I saw. The reason is here. But if it is pethidine, 100 milligram to 150 milligram. So you can save a lot of money on that. And chance of adverse effect will be less. Now, I'm really heading towards the mechanism of action. When you got a tissue injury, what will happen presynaptically and postsynaptically? You cut some part of your finger. What happened actually in the free nerve ending, and after that what happened? How you feel pain?
When we cut our finger, they release substance P,
Very good.
and then
So
they
what
stimulate the
happened?
nerve receptor.
Yes, good. So we have presynaptic membrane, we have postsynaptic membrane. So presynaptic membrane actually is here all your free nerve endings. So what happened if you're exposed to a hot temperature, or if you are exposed to a sharp object that cut your finger, you immediately you feel pain. So what happened in the presynaptic nerve terminal? There is an opening of the calcium channel. So opening of the calcium channel in glutamate and substance P are those neuropeptides they respond initially. So what happened? This glutamate again they transfer to postsynaptic membrane, and they activate NMDA receptor. Substance P also is the same, or. So what happened? So this secondary neuron actually in your dorsal horn and also lateral funiculus. So you have two area of pain modulation, presynaptic and postsynaptic. Only morphine acting in both presynaptically and postsynaptically. So what happened presynaptically? It inhibit calcium channel. So if you block presynaptically calcium channel, what will happen? There will be no glutamate, no substance P. However, morphine has a very unique capability in postsynaptic membrane, they open potassium channel. So if they can open the potassium channel, it's a huge opening. So what they do, they actually take it to hyperpolarization state. So we know nerve have depolarization, repolarization, and hyperpolarization. It means if a cell's resting membrane potential is 90 millivolt, if you give morphine, it will go to 120 to 130 millivolt. So what happened? It go far beyond the threshold value of its action potential. So that is hyperpolarization. So presynaptically, you are preventing release of excitatory or pain-causing neurotransmitters. And postsynaptically, what you are doing, you're opening voltage-guided potassium channel. So that actually bringing hyperpolarization into postsynaptic membrane. So whole dorsal horn cannot react if 1%, 2% also neurotransmitters are coming, but they cannot be transmitted to third order neuron level. Okay, so what happened, if you give morphine, it will reduce activation of cyclic MP formation. So it eventually it's gonna close voltage gated calcium channel presynaptically. On the other hand, once you block calcium channel, you cannot release all the excitatory neurotransmitter, likely glutamate, substance P, acetylcholine, and histamine. Uh, in addition, what they do, they're opening potassium channel and causing. So now is coming IPSP, inhibitory postsynaptic potential. So that is happening postsynaptically by opening of the voltage gated calcium channel. Fahamta?
Faham.
Okay. Okay. Now this will take little bit of time because 2, 3 nations they try to capture, they try to do monopoly with this business. So don't take it lightly. Morphine is not a very ordinary matter. Morphine is matter of country policy. Morphine is like oil, oil is a policy for international politics. Jews, USA, Western world with the Arab, morphine also kind of same. But volume is so smaller, but the revenue is so big. So you really, really have to give deserved respect while you are studying opioids. Now, see this table very, very carefully. And this table, it saved us few time to cancel our license. Why? Because in orthopedic ward, if you place in orthopedic ward, whole night you cannot sleep because all patients went for reduction, fracture patient, fracture pains are severe pain. Whole night they cry, they shout, they scream. They'll be asking, I cannot sleep, I have pain. But once you give somebody morphine, you actually sacrifice your sleep. He will be sleeping after taking morphine, but you cannot sleep. The reason, we used to really, make our ear very sharp. Ever, my patient is telling after morphine, doctor, I feel to vomit. If we feel to vomit, and if I cannot run with the naloxone, I have to sacrifice my license. So why I'm becoming on that now? A post-operative patient or fracture patient, they have to get an analgesia because those are very painful situations. Periosteum tear, bone cortex structure pierce or broken, discontinuation is a big pain matter. Somebody went for through a operation and operation already done. So all the viscera going to release lot of pain causing neurotransmitter internally. Visceral pains going to come. So what happened? They need analgesia. So only one reason, justification of giving morphine, but all are byproduct of combating with analgesia. Now, what happened? You never know this person is very sensitive or he is an alcoholic, he has some COPD disease existing. Morphine after analgesia is going to suppress the respiratory center. So if somebody's respiratory center is suppression, they're going to die. So that is the risk. Orally, this is also a benefit for us. Inhibition, right? Inhibitory effect. It can really inhibit your cough reflex pathway. We don't want only analgesia. We want a post-operative patient should go for a very sound sleep. So this look absolutely fine, nothing wrong, except respiratory center depression. Now, it will never go directly to respiratory center depression. It will give you some clue. What are those? Before going, if dose is that big, what will happen? It will reach into your chemoreceptor trigger zone. So normally a morphine patient never ever going to vomit ordinarily. If dose is higher or patient is too sensitive with the morphine, only then it crossing, it reaching into the CTZ center. So if it is reaching to CTZ center, after CTZ center, the next border is your respiratory center. Okay. Before that, I want to check whether patient is vomiting for anesthetic drug or for my morphine. It can occur by both. I cannot, if somebody want to vomit and I cannot stop giving morphine, I have to justify why I don't want to give morphine. Immediately, I'll check patient's pupil. Why pupil? Because pupil also still before going to your respiratory center, edengal vestral nucleus. So Edinger-Westphal nucleus is directly responsible for pupillary contraction. So I had a patient, post-operative patient, I injected morphine, patient want to do vomiting, patient pupil is shorter. Very soon, if I don't give naloxone, patient respiratory center going to depress. So that is this really this much interconnected. And if you miss it, doctor, I want to vomit, you finish. So that's why we always hate people, at night who want to get morphine, because we know he going to sleep, but whole night I have to sit when he call me. Euphoria, that is while you giving analgesia and sedation, this person in his dream, he'll go to his childhood. He'll go to the most sweet memory he has in his life, euphoria. Okay. Very high dose, there will be some rigidity, convulsion may can occur in a very high dose, but before that they actually die with the respiratory center depression. So this step will very, very crucial. So let's go one by one. So what this nurse is doing, you can see this is the drug for any kind of orthopedics procedure, like you want to do fixation and reposition of fracture fragments of the bone, and you want to do the plaster of Paris, you cannot do it without morphine. Patient will kick you with the intake leg without morphine. They will never allow you, but he is now enjoying. You saw the facial expression? Can you see?
Yes.
So the reason he is enjoying is not the reason the female nurse, but he is under morphine. So he now enjoying his reduction procedure and also the Paris plaster. The reason he is under morphine. So how you can achieve it? Analgesic action, it is central and also peripheral morphines. So what happens centrally? It reduces pain perception, reduce reflex responses to the pain, the descending pathway. It also inhibiting. It increase patient pain threshold, accompanying with the sense of well-being and relief because of your euphoria. How we have done all this? Previous slide we have discussed about the presynaptic events by blocking calcium channel, reducing release of pain causing neurotransmitters, and postsynaptically we are causing hyperpolarization. So if we by that these are the behavioral, those are molecular changes. Here you can see the behavioral changes. So although it is very painful, but he is not feeling. So he is allowing the nurses to do the appropriate procedure recover. So his pain absorption actually increasing. His responses toward the pain or descending pathway is reduced. Feeling of pain also already been reduced. So these are the behavioral change occur. Mechanism I already just discussed. Okay. So if you give morphine, actually it also going to enhance the secretion of endogenous opioids. So that's how the first pharmacological effect of morphine is analgesia. So what benefit they have after morphine? So reduce pain perception, reduce reflex pathway, increase pain threshold. How? This is the mechanism. So after analgesia, we are very much concerned about the respiratory center depression. So all opioid analgesics can produce significant respiratory depression by brainstem respiratory center. How? You know the constant. You have done your respiratory center, block, right? Okay.
Yes.
So what happened in brainstem? It reduced the sensitivity of carbon dioxide tension. So normally a patient with COPD or when there is a shallow breathing, what will happen? Inside the blood, carbon dioxide concentration will be increased. So increased carbon dioxide, it will go to your respiratory apneic center and asking them to fast breathing. So if you do the fast breathing, what will happen? You will exhale the carbon dioxide, but morphine make them insensitive, telling okay, lying, just sleep. So carbon dioxide causing vasodilatation. So decrease cerebral vascular resistance, increase cerebral blood flow, increase intracranial pressure. So decrease respiratory rate, minute volume, and diet volume. So that's why there will be severe respiratory depression. And unluckily, if this patient already having COPD, mashallah, see you in the court. So that's why before you prescribe to anybody morphine, 6 times we are asking them, have ever you had bronchial asthma? Are you a smoker? Did you have any history of tuberculosis? So we really have to check lung function test. Otherwise, these things will happen very quickly and you will see severe breathlessness of the patient. Okay, so number 2, inhibitory action on the brainstem respiratory regulatory center. Mechanism already been explained. Number 3, cough suppression. This is the best drug for dry cough, which is dextromethorphan. It is without sedation. There are some reason, like I have sometime insomnia problem. So what I do, in Malaysia, you can buy gold, diamond easily, but you cannot buy sleeping pill so easily, an antibiotic. If I go and ask into the clinic sleeping pill, it's like I'm asking for their kidney. They are so sensitive. So what I do, I'm a pharmacologist also. I'm not less smart than them. So what I do, I said, Ade bole bagi codeine syrup. They look at me, why? Oh, Lamar, I'm taking SA inhibitor. I'm having very tough dry cough. So okay, okay, just take. So this is why you don't ask for dextromethorphan. No, 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 no. I don't want dextromethorphan. Please give me codeine. So what happens if I take codeine syrup? First, it is very strong cough suppressor. Secondly, the codeine. I didn't highlight it because you have to be careful. I don't have any respiratory problem. I'm not a smoker, So my lung condition is good. So sometimes for overcome my insomnia situation, I prefer codeine. Tapi for general people, the best ideal drug is the dextromethorphan. So once you're giving somebody codeine, ask them to take at the bedtime. Okay, so it suppress medullary integration of the cough reflex. So please, bacha sindiri cough reflex. Okay, so it suppress very strongly. The best drug for cough suppression is the dextromethorphan or codeine. Sedation. So as I said, patient with after operation, you want them to have analgesia effect. Also, they're getting sedation, so they will not call you anymore. They will be sleeping very happily. Okay, sedation less sedative than, but it is sufficient enough to induce their sleep. So we got 4 inhibitory responses by morphine. Number 1, it was analgesia. Number 2, dose dependent suppression of cough center. Number 3, suppression of the cough reflex, and it caused sedation. So these are the very 4 important inhibitory responses. However, there are 2 life-saving for doctors, actually. Life-saving adverse effects are there. Nausea and vomiting. Opioid analgesics can activate brainstem chemoreceptor trigger zone to produce nausea and vomiting. And that is your trigger. This fellow going to, now after CTZ center is your brainstem. In brainstem, you have cardiorespiratory center. Patient die actually not with the respiratory failure, cardiac failure as well. So this is only last call for you. You have to respond here. And sometimes what we used to do, we teach our patient, I'm giving this drug to reduce your pain, but some people having problem. If you feel to vomit, nausea after this drug, please call me immediately. Even I tell it to, we used to tell to the nurse also, that I'm giving this patient morphine, please put a red flag in this patient and ask him whether he want to vomit or not. Once he try to vomit, it means drug already in CTZ center. If I don't give naloxone, soon it will go and inhibit the cardiorespiratory center. So this is a very, very important call for us. Otherwise, who care? And you just imagine another situation, patient had appendix operation. So they cut until so deep and now patient want to vomit. How painful it can be. And there will be a chance of, tear of their internal stitches. So that's why we have to be, we have to be ready with the anti-emetic drug also. Meiosis. So this vomiting because of anesthetic drug or not, I'm not sure, because they come from operation after before 1 hour. And halothane also can cause vomiting. So I have to check whether it is because of morphine or because of anesthetic drug. Anesthetic drug will never cause meiosis. whereas morphine will cause pupillary constriction. Mu receptor present in the danger vessel. See, Allah is so scientific. He put one just checking, reconfirm mu receptor into the eye. Only reason, without morphine, endorphin will never cause your pupillary constriction. It's only morphine will bind with this mu receptor. Example, medical board are coming. There is a mishap happened. You prescribe somebody morphine. This patient happened to have previously COPD and patient died, and this matter goes to the court. Only one event can save your life, your license. That is, there was no pupillary constriction. Any medical board in the world cannot touch you because this is that much specific. Without morphine overdose, to reach at brainstem and respiratory center depression, you cannot have it until you have meiosis. So if you have meiosis, patient vomited, then patient die with the cardiorespiratory failure. I'm sorry, you have to be in the jail. You just see so many movies on all these events. Okay, with larger dose of morphine cause pinpoint pupil. It is a damn established medical phenomenon in the practice. Without high dose of morphine, where patient die, you must have to see pupillary constriction. That is the confirmatory. It is because of respiratory center depression because of morphine. Okay, truncal rigidity. There will be spasm of the muscle. I think before die they show some rigidity, but it is too late. When you give your medication to the drug, next day you see your patient is very happy, or abuser staying in terrace, they'll be thinking, oh, I was in White House yesterday. They can dream whatever they like. Euphoria. Typically, patients intravenous drug user, abuser, especially who receive IV morphine, pleasant floating sensation with lessened anxiety and distress. And you'll be not surprised if they say, hey, yesterday I dated with Lady Gaga or Taylor Swift. They can say whatever they like because that's why they are buying this medication. That's why they're doing the addiction. So pharmacological effect all done. There was some 4 inhibitory effect. There was 4 stimulatory effect. Among stimulatory effect, 2 is very, very crucial for medical professionals. Those are nausea, vomiting, and number 2 was pupillary constriction. So please, you always have to check these 2 signs once you prescribe somebody morphine. Finally, this is the use for the abusers, euphoria. Anybody here can remember I did mention patient with myocardial infarction, even paramedic, before take them to hospital, you should prescribe morphine. Can you remember it? Can you remember?
Yes, doctor.
Yeah. It is literally a life-saving method. Now, what we have done with the central effects of morphine, inhibitory, excitatory. There are 3 or 4 very important peripheral effects are there. Among them, number 1 is, what happened?
Truncal rigidity.
No. Can you see my slides?
Yes, doctor, but I think you haven't loaded the words.
No, you can see my slides.
Yes.
But I cannot see. Suddenly gone. How? Hmm. Seriously, my slide lost. Okay. Now I can see the picture of Muhammad Hafizul. Only I can see Hafizul. There is no slide. Okay. Tapa, I think I do not need slides. You guys can see it, right?
Now we cannot, doctor.
Sorry. Give me 10 minutes. I think after 10 minutes class will be finished. Boleh tahan tak?
Boleh.
Class boring ke?
No, doctor.
It's going to finish soon. 10 minutes, I think, maximum. Aduh. Shit. When is your exam?
Monday.
This Monday.
Next Monday.
Okay. Now, quickly, we should go with the peripheral effect. So, firstly, we have to see effect on the heart. So, in the heart, it actually causes bradycardia. Okay. So, again, it's a concern for us. We have to check whether patient having previous heart failure or not. If patient having previous heart failure, we have to be very, very careful. Okay. Secondly, hypotension because of release of histamine. And this histamine play magic for MI patient. It causing vasodilatation, not only cerebral, cardiac also. So histamine actually causing generalized vasodilatation. So what happened? Reduce peripheral, the venous return, preload and afterload. So it is good for the MI patient. It is a must. Somebody having MI, it not only reducing the pain but also reducing the the outcome of the patient. It has a good prognostic value, so it's a must. It is in the protocol. You have to give the mi patient morphine. You have to prescribe GIT. There will be constipation. I got a very funny story about it. I can see one guy is a look like a addicted person, come with the parents. Parents ask them to admit into the hospital, but that boy is telling, "I swear on Allah, I don't do any kind of addiction." So what we did, I asked them, "Can we see your arm? Open your arm." We saw his arm got a lot of multiple needle injury. Another thing, you just ask them, how is your bowel habit? Oh, I rarely go to toilet. Once in 3 day, 4 day, or 5 day. Constipation is a very dependable sign of morphine abusers. Okay, because somebody, if they take heroin, you cannot see any needle mark. So how to know about it? You'll be seeing they're unnecessarily energetic. They love to speak for long time. They're very restless. They cannot sit in the one place, and you just ask them, do you having constipation for long? Yes, morphine will cause signature constipation. Increased tone of smooth muscle in the GIT, so there will be decrease in the motility. So sphincter is contracted, but the muscle tone is increased. So there will be reduced GIT motility. So severe constipation they have. This is also very signature features with them. Interestingly, it can cause contraction of neck of the bladder. So anybody having previous liver disease or obstructive jaundice cannot give them. It will worse their situation. Okay, it can cause contraction of the biliary neck of the bladder, your gallbladder. So if they're constricting neck of the gallbladder, it worsening the obstructive jaundice features. Also, it can contract the sphincter of OD in second part of the duodenum. So bile will be not releasing. There will be severe disturbances in the lipid metabolism with this patient. In kidney, it has some good function, especially on the bladder function. But what happened? Renal function is depressed by the opioid because renal perfusion going to reduce. Previously, you caused bradycardia. you cause vasodilatation. So what will happen? Blood pressure is decreased. So once blood pressure is decreased, there will be decreased renal flow. If there is a decreased renal flow, there will be less production of glomerular filtration. So what happens? It can inhibit tubular sodium reabsorption, and there will be increased tone of, so that they will be having frequency of micturition. So sometime even if needed, we can do catheter for the patient. So not so obvious, but some effects are there. You can see flushing on the face because of release of histamine. On uterus, so even mother is crying with the labor pain, but you cannot give morphine not only for the baby, but also it will prolong the labor because it causes relaxation of the uterine muscle. Okay. Now we go for clinical uses. So far we have learned classification. So far we have learned mechanism of action. So far we have learned pharmacological effect. Now is the time we have to combine all information and we have to justify where and why we want to use. So it's the tremendous, the best analgesics in the world, but not for ordinary pain, deep-seated visceral pain, okay, post-operative pain, cardiac pain, fracture pain, cancer patient pain, severe pain of dying patient. We saw in many movies when soldier they get the shot and before die they actually take morphine because it will reduce their suffering while they're dying. So dying patient, senile patient, aged patient when they're dying, cancer patient when they're dying, many times we give them morphine. So what will happen? You come back after half an hour, you'll be saying there is no more life, already dead. So these are the analgesics indication of morphine. There is no other alternative of morphine or pethidine here. There is another, scientific, very smart use of morphine is acute pulmonary edema, especially nocturnal. So what will happen if a heart failure patient, heart is not good enough, or if there is any mitral stenosis patient, so what will happen when you are lying flat, the venous return, all this, more blood coming to the lung, and lung want to drain those blood into the left atria, but left atria is already full. So what happened? Through pulmonary vein, blood has a tendency to go back and cause pulmonary edema. In those cases, we can do shunting. What is shunt? Morphine cause vasodilatation. So at night, when you are lying flat, when you are lying standing, you have gravitational force, right? Many blood will remain in the periphery. But when you are sleeping in the bed in supine, what happened? Your venous return is increasing. So patient having more problem with the pulmonary edema. So morphine release histamine and causing vasodilatation. So transferring of the blood or shunting of the blood from heart and lungs to peripheral organs. So reduce preload and afterload. Trust me, morphine is considered one of the drug of choice for pulmonary edema. So we have analgesics use. We have pulmonary use of in pulmonary edema. Very good drug for anxiety. Until the death anxiety also you can reduce. So shock, hematuria, heart failure, MI, myocardial infarction, patient in a severe death fear. This is the drug of choice to reduce those extreme level of anxiety. Control cough is another therapeutic use with either codeine or dextromethorphan to reduce dry cough. You already know one prescription. Anybody coming to you with dry cough problem, you answer with the dextromethorphan or codeine. Control diarrhea, severe watery diarrhea. Antibiotic also, it will take some days to produce its effect. But just now you studied in pharmacological effect, morphine can cause severe constipation. So why not use that theory for a diarrhea patient? So severe uncontrolled diarrhea, mostly not infected loperamide and loperamide or diphenhydramide you can give for acute diarrhea patient. Pre-anesthetic medication. As I said, all the fentanyls or newly synthetic morphines are alfentanil, sufentanil, and difentanil. How many pieces of ampoule I broke, I forgot. Pre-anesthetic. So why? Because if you know tomorrow you're going for a heart operation, how stressful you will be. And that stress will increase your blood pressure. So in operation table, then you will have more bleeding. So one night before or 2 nights before, we already start giving them fentanyls group of drugs, sedatives, so that what will happen? It will reduce the stress. So pre-anesthetic, during anesthesia, complication will be lesser. Regional anesthesia, as I said, epidural is the choice of drug for modern day mother. Labor pain, whoever they face, they know how much painful situation it is. But Australia, Singapore, Europeans, they already become, I think Malaysia also started, but you will get it in a private, good, sophisticated hospital. I don't believe maybe you'll get this in government hospital, but Malaysia also have it. Only 2 hospitals in my country, they can give epidural anesthesia. The advantage, it is only inhibiting your spinal nerves. So you can easily deliver baby without feeling any pain. So it is the drug of choice for epidural anesthesia. For you can give it, or even you can give some dying patient or delivery patient, but more common with the delivery patient. Now, what are the adverse effects so far we have collected? We know nausea, vomiting, respiratory center depression, pinpoint pupil, and remember until here, and hypertonicity of the muscle. No, none of you, I think, have to study it. You already register in your brain. You'll never forget it. This is for commonly all students. Some better student you have to increase because of increased carbon dioxide tension. There will be increased intracranial pressure. Postural hypertension because of histamine. Urinary retention because of effect on the kidney. Histamine, it will cause allergy-like features, isn't it? Constipation, bronchospasm, tolerance and dependence are the chronic users problem. Okay, somebody having chronic asthma, it will cause immediate bronchoconstriction. Tolerance and dependence for the addicted people. So contraindication, where you cannot use it. Please remember this word. Orthopedician surgeons will kick you out of the ward if you give morphine to patient with asthma and COPD. Any kind of COPD, trust me. And it is only if you want to ask one previous history or past history for a morphine prescribing patient, that is, do you have any respiratory problem? If so, you have to go for other drug, maybe pethidine. Relative, okay, base only. Now, morphine poisoning, patient mostly actually unconscious, cyanosed, decreased body temperature, severe respiratory depression, and there maybe you'll get like shock features of cold, clammy skin, low BP, and jaw will be relaxed. Pupil will be pinpoint pupil is the confirmatory sign your patient having morphine poisoning, because anybody can sleep, but pupil is like a needle also cannot go through. It will be that much contracted pupil with the morphine. So morphine treatment, you have to give ventilators because their respiratory system is compromised. So artificial respiration. You have to give naloxone or naltrexone. It is a practice. You cannot prescribe morphine until you have the stock of naloxone or naltrexone, because you never know which patient going to respond abnormally with the patient. I think saying so, there is the only difference, and some addiction, abuse, addiction, dependence you just can do by yourself. Okay, is it usable for the session for you?
Yes, doctor.
Yes, doctor.
Yeah, I think class was going so openly, prolonged, lambat. So 2 to 3 slides, I don't think so. Dr. Azli will set question from there. If you ask me, I will check this student knowledge about morphine classification, pharmacological effect, clinical uses. But you are paying tuition fee only not to pass this exam, but to prepare yourself for year 3, year 4, and year 5 also. I think whatever we have discussed, if you keep the slide until 5th year, you need not to study a single word about morphine anymore. Whether you are placed in orthopedic, where you are placed in ICU department, or you placed in anesthesiology department regarding morphine, these are the everything about morphine. Yeah, I think that's all. Ada question tak?
Doctor,
Yeah.
can someone die due to pain?
Yes, neurogenic shock can. If you're exposed to in those kind of situation for long, you can die with a neurogenic shock.
All right, doctor. Thank you.
Any more question? Even normal delivery, if baby is arrested somewhere in the delivery pathway, to me, delivery is the most dangerous exam for mother and for the parents actually. If everything goes smooth, no issue. But we saw so many complications. I don't know whether I have told this story or not. One of my friend, lady, her name was Mithila, one of the richest girl in our bachelor. So after marriage, to do her delivery, she went to UK to deliver the baby. She died in UK with intravascular disseminated coagulation. And please study at the when you are free, or if I cover any time anticoagulant, try to give me some time for anticoagulant. Pregnancy, what is the relationship with intravascular disseminated coagulation? Even in Liverpool Hospital, technology couldn't save her. So delivery is a very complex matter. So many things are involved. So if any baby is stuck anywhere and you don't have the procedure or expertise to deliver the baby, so many times mother died, right?
Yes, doctor.
Yeah. So with pain, people can die, and that is actually neurogenic shock. Okay. So maybe if possible, any more topic is coming, try to inform me little bit early so that I can prepare better.
Okay, doctor.
Okay, guys, take care. Huh?
Thank you, doctor.